So hello, and thank you all for joining Partnership to Improve Patient Care for our webinar, Unpacking ICER's Models Assessing COVID-19 Treatments. My name is Thayer Surratt. I am PIPC's Deputy Director, and we are excited to walk through this topic with you. This topic has gotten a lot of buzz lately, and we know you have questions about the nuances of the models and its potential implications for patients and people with disabilities. We've gathered together a panel of experts who I hope can shed a bit of light on this, as well as answer all of your questions. There is closed captioning available for this webinar, so if you would like to access it, please click the CC button on your Zoom screen. For some light background, for those of you who may not be familiar with PIPC, we are a coalition of organizations representing patients and people with disabilities, providers, researchers, and innovators. Our main driver is patient centricity in the healthcare system, and we were founded to advocate for the formation of PCORI in its current form, conducting comparative clinical effectiveness research. As value assessments have become an ever larger focus of our healthcare conversation, we've been very focused on ensuring patients and people with disabilities are deeply involved in these conversations and that value assessments are conducted in a way that shows value to the patient, not just the payer. We've been paying very close attention in this vein to the Institute for Clinical and Economic Review, or ICER, which is an organization that conducts cost effectiveness analyses. ICER states that it's an unbiased third party, which is trying to determine the true quote unquote value of drugs. But ICER is largely funded by insurance companies, along with Arnold Ventures, and its studies focus on showing value to insurers, relying on cost per QALY methodology. Colin's going to dig into this more, but the QALY is a metric that is known to discriminate against those with disabilities, chronic conditions, and who are older. ICER's assessments are generally conducted too early and in a rush to provide results to insurers, which results in them omitting critical real-world data, meaningful engagement by patients, and outcomes that matter to patients. So I think it inspires some hope that we're starting to see some progress for developing COVID treatments and vaccines. We still have a very long way to go, which we all know, but strides are being made to combat this really difficult crisis. Just as we started to see this progress, ICER has released 2 models designed to assess treatments for COVID-19. ICER used these models to conduct an assessment of remdesivir, the first drug deemed efficacious for COVID-19. It has indicated that it will continue to revise this model and run assessments of additional drugs as they prove efficacious. ICER has since revised the model once. For those of us who are familiar with ICER, we expect haste. They often begin assessments prior to FDA approval, but this specific assessment was even more hastily conducted than usual with some really overt flaws in the model. This is particularly concerning to us given the huge toll that COVID-19 is taking on our nation. So with that in mind, I am really excited that we have these great panelists here that can unpack some of the serious issues that we have with this model, including the use of the QALY, omission of societal perspective, and omission of stakeholder input. So I'm going to turn this over to Colin Killick, who is the Executive Director of the Disability Policy Consortium, to get us started. I will be monitoring the Q&A throughout, so feel free to chime in there, but we are going to have an extensive period for questions at the end, so we all look forward to answering those questions then. All right, Colin.
Thank you so much. Let me turn off my air conditioner for a moment, make sure you all can hear me clearly. So my name is Colin Killick. I'm Executive Director of Disability Policy Consortium. We are a civil rights advocacy and research organization based in Greater Boston, run by and for people with disabilities. I've been interested in this issue of QALYs since I was a grad student at the Kennedy School, and I just kind of couldn't believe that this measure that was so widely used in public policy circles was essentially discriminatory pseudoscience, and I've been trying to fight it ever since. So I'm here today to talk to you about QALYs. A quick note about DPC. PIPC is a big tent. People have various positions. So speaking only for ourselves on the drug issue, we want to bring drug prices down. We've fought for maximum price caps in here in Massachusetts and for importation, for intellectual property reform at the federal level. the problem isn't bringing down drug prices, the problem is QALYs. So I'm going to talk about these today, what they are, how they work. I have extra slides I can bring up in Q&A because this is a complicated subject, but let's get into it for now. So next slide, please. So basically, what is a QALY? A QALY is a value put on somebody's life, right? QALYs are a statement of how valuable someone's life is on a scale from 0 to 1 based on their disability. Someone with a QALY value of 0 is dead. Someone with a QALY value of 1 is in perfect health. People with disabilities are placed at points in between. So, you know, someone with diabetes, you can see there is around 0.8. That means that their life is worth 80% as much, according to people with QALYs, as someone with no disability at all. Someone with rheumatoid arthritis around 0.5 or half as much. Someone with cancer further down. So depending on what disability you have, how disabled you are judged to be, you are further down the scale. There are actually certain conditions that may even put you at 0, according to these folks. There are procedures being as bad as being dead. So the question then is, where your QALYs come from? How do they get to these numbers, these very specific numbers? Next slide. So let's start with where they don't come from, right? QALYs are not based in a meaningful way on the views of people who have the disability in question. They are not derived from the views of experts on the particular condition. In fact, they don't really come from medical data at all. Where they do come from, next slide, is opinion polling, right? Random opinion polling, calling numbers out of the phone book. And I say, there's nothing wrong with opinion polling. It's the same kind of polling that's, you know, being used in presidential elections, but it's used to measure opinion, not to divine scientific fact. You are limited by the knowledge of people picking up the phone. And so here's how it tends to work. Somebody picks up the phone randomly, let's say, you know, I get a call about this, and I don't know anything particular about these conditions. Someone's given 2 descriptions, one of a healthy life, one of a particular disability. That disability may or may not be identified. But the disability description is based on a data that comes out of a quite biased survey itself, called the EQ5D, that I can get into. They'll give people a description. So for spinal cord injury, they might say, you know, people with spinal cord injuries are confined to bed. They can't bathe or get dressed by themselves. They report, on average, high levels of pain and anxiety, right? They'll describe that, and they'll describe a state of perfect health, and they'll say, you have a choice between living X years with that disability or 10 years of a healthy life. And they'll keep increasing X until the person can't choose, you know, can't decide between, say that they couldn't choose between living that many years with a disability or 10 years with a healthy life. And they therefore conclude that the value of the life of someone with that disability is 10 divided by X. So if X is 20, someone couldn't decide between 20 years of life with that disability or 10 years of life with no disability at all. They conclude that X is 0.5, meaning that someone with that disability, their life is worth half as much as the life of someone with no disability at all. This is how it's calculated. They take the average, you know, across all these responses. Next slide. So yeah, so here's our example. So our example person picking up the phone, Bob, 40-year-old, non-disabled, white, cisgender man. He picks up the phone, they describe a spinal cord injury to him with that description that I gave you, and he picks. And for him, say X is 20, he said, yeah, I have to live, if I was given the choice between living 20 years with a spinal cord injury, as you've described a spinal cord injury to me, I don't know anything about it inherently, or 10 years with no disability at all, those sound about even. That means that the QALY value for someone with a spinal cord injury is 1/2, right? Because 20 years with a spinal cord injury is judged to be equivalent to 10 years with no disability at all. And this is how it's done. And this is done for, not necessarily even for each condition, because they figure out how people value certain combinations of these disease states and tally it up mathematically. But this is the basic idea, is it's opinion polls of people to determine how valuable other people's lives are. It's not the people whose lives are being discounted who have input on how valuable their own life is. I can get more into this in the Q&A if people want more details. I have slides for it. But for now, let's move on. So then, okay, these figures are calculated. What are they used for? And the big thing is cost-benefit analysis. So if treatment A costs $100,000, or it costs $1 million, and it would save the lives of 1,000 people, and I'm a state Medicaid plan person, or I'm someone working in an insurance plan, if I think that saving one life is at least worth $1,000, it would be worth it for me to pay $1 million to treat 1,000 people with this drug, right? We're paying $1,000 per course of it. But the quality proponents argue, well, but you have to look at how valuable those lives you're saving are. They argue all lives are not created equal, right? So if, from using the figure from our example, a spinal cord injury is worth, the life of someone with a spinal cord injury is only worth half as much as the life of someone with no disability at all, then they say, well, each of those lives should only really count for half a life. So spending $1 million on this treatment wouldn't be worth it if the value of saving one normal life is $1,000, because you're really only saving half as many true lives. Each life you're saving only counts for half a life. It's quality adjusted life years. You're only saving half as many years. You only get half credit. Also, there have been proposals to use QALYs to decide who gets treated. And then we're seeing this start to come up with COVID. If there are limited supplies of a resource, people argue for providing treatment preferentially in ways that will save the most QALYs. That is to say, that will save the lives of the people who are judged to be least disabled first. And that's really particularly troubling. Next slide. And so one thing that comes up with COVID in particular, if you look at ICER's analysis, that's troubling is they use these things called age-adjusted utility. Because COVID is interesting in that because we're dealing with a viral pandemic, oh, sorry, my video cut out. There we are. Because we're dealing with a viral pandemic, a whole huge swath of people are coming in. It's not, COVID itself isn't hitting people necessarily evenly. But so what they've done is there are utilities for people of certain ages, right, that have been calculated by researchers. They say on average, a 75-year-old has this level of disability. We should discount the value of their life by this much. So what they've done is look at the average ages of people contracting COVID and use that to say, well, we should on average discount the value of remdesivir by this much because the lives that it's extending or saving, the suffering that it's removing, it doesn't really fully count because the people it's saving or helping, their lives are worth less already. And this means that you're already reducing the value of treating older patients. This is bad enough because already the way a lot of states are making these decisions are discriminating against people based on age. The older someone is, the lower priority they are to get treatment. Cost effectiveness analysis already deprioritizes older people because they have fewer QALYs left to gain, right? Someone is 70, even keeping them in, keeping a current condition from killing them, they are naturally only going to live, 20, 30 more years at most. This makes that even worse by saying that their current years of life are also less valuable. And this brings up an important point, which is that federal authorities have recognized that cost effectiveness thresholds like this are discriminatory. They were banned under the Affordable Care Act. And increasingly, during this COVID crisis, there have been findings that using these kinds of standards are discriminatory in the context of COVID and of crisis standards of care, which I will get to momentarily. So next slide, please. So there are direct QALY connections to COVID and indirect. We're talking particularly about remdesivir, this study, and these questions that basically come up fundamentally. When you strip away the technical detail in ICER's analysis, we're dealing with these very basic questions of how much should this treatment cost and who should get it, right? And they're arguing that QALY should be used to decide, and that's going to have ramifications. It's going to decide how available is it, right? How much remdesivir do states purchase to use? It's going to decide, certainly have an impact on how much it costs. And it's probably going to impact prioritization because states are already rationing care, rationing treatment. QALYs could very well be used to ration treatment, to ration, okay, if you turn out to not have as much remdesivir on hand as you need, are QALYs going to be used to determine who gets it and who doesn't, based on how much utility there is to gain? And then the same analysis, as ICER is saying, they're going to apply it to other things beyond remdesivir as the pandemic continues. This gets all the more concerning about a potential vaccine or a potential cure, right? We could wind up in a circumstance where governments are reluctant to provide enough of that treatment to go around because they are relying on an analysis that says some people aren't worth the expense of curing them, aren't worth the expense of keeping them alive. That's the basic logic of the QALY. Next slide. And on that subject, I think there are other places during this pandemic where what I would call QALY logic is showing up. QALYs aren't being used explicitly, but this same notion of some people's lives are worth less than other people's lives based on their disability is being explicitly implemented. The big area for this is crisis standards of care. So this is where states that were facing rushes on their emergency rooms, their ICUs, they didn't have enough ventilators to go around. We're putting these protocols in place to determine who gets treatment and who doesn't, who lives, who dies, who gets a ventilator. And they were basing it often explicitly on this notion, it's true here in Massachusetts, of maximizing life years, right? That younger people should be a priority for treatment, that it's not about saving the most lives, but preserving the most life years. The more potential years you could live, the higher priority you get for treatment. That means the older you are, the sicker you are going in, the less treat you get. And in fact, states were using categorical exclusions in some places, saying, for instance, in Alabama, initially, if you have an intellectual disability, you don't get treatment for COVID at all. Here in Massachusetts, there was a 5-year survival threshold where, say, if you are predicted to have less than 5 years to live because of a disability, you are at lower priority for treatment. Unfortunately, here there's been some progress. A couple of weeks ago, the Office of Civil Rights at the Department of Health and Human Services found that many of these criteria that were used in this case in Tennessee's crisis standards of care were discriminatory, violated federal disability rights law, and they came to an agreement with the state of Tennessee to change their standards and make them non-discriminatory in ways that will hopefully ripple out and impact other state standards. And the last thing I want to talk about is a tragic case out of Texas, and this is one life, this is one person, one hospital's decision. But it's instructive because it's a decision that was morally abominable, but aligns exactly with the logic of QALYs. Michael Hickson was a professor of philosophy, was a husband, I believe a father, and he was a Black man with a disability in a wheelchair. He contracted COVID, he went into the hospital, and at some point a court-appointed guardian was put in charge of his medical decisions, and over the objections of his wife, that hospital and that court-appointed guardian decided that his life was not worth saving from COVID. It was not worth continuing treatment. It was not worth giving him remdesivir, in fact, because he was in a wheelchair, because he couldn't walk, and that meant his quality of life was too low to be worth saving. They withdrew treatment, they withdrew food, and they deliberately let him die. And that is, at its core, the fundamental logic of the QALY, that some people's lives should not be saved, that it's not worth it to save them because they have a disability. And now I'll hand it back.
Thank you very much, Colin. All right, I am going to now turn it over to Adolph Falcon with the National Alliance for Hispanic Health. Thank you, Adolph.
Thank you, Theron. Thank you, Colin. It's, you know, we can have these policy discussions, but we always run into the possibility of forgetting the people. And this has serious implications for people. COVID-19 has already had a disproportionate impact on underserved communities. And at the Alliance, we're particularly concerned that this concept of value-based purchasing is going to further exacerbate what has been a disproportionate impact. And it's not, it has to do with the concept of ICER, which is really a kind of one-size-fits-all concept. But when we look at COVID-19, for Black and Hispanic communities, there's been a particularly high incidence, and part of that is thought to be tied to the higher rate of underlying conditions. And also the fact that disproportionately, in Black and Hispanic communities, these are the workers that are keeping the nation functioning right now. These are the essential workers that are the nurses, that are the staff that are keeping hospitals safe, that are staffing the grocery stores, that are continuing to process meat and other food products, that are in the fields picking food. In fact, we had an outbreak in Kennett Square, Pennsylvania, a mushroom picking field, and we actually had to move testing and services directly into the field while those folks were still being required to work. So this whole idea that you can put a single price and you can use a one-size-fits-all model simply doesn't reflect the reality of COVID-19 today. Next slide, please. And we are particularly troubled by the data being used. ICER standards use available clinical trial data, but we have to look at what that data is. And for decades, despite federal requirements for inclusion, clinical trial data has not included racial and ethnic communities. We've had gaps with regard to gender. We've certainly had gaps with regard to age and disability. And just looking as personalized medicine is moving to genetic-based studies, if you look at the genetic database, only 19% of that database is non-European. But if you dive into that number even further, the vast majority of that, somewhere around 3/4, is data from Asian studies outside of the US. So when you really dig down to the numbers, somewhere about 3% of those participants are African American, and somewhere around less than 1% are Hispanic. Yet at a time when we have COVID-19 disproportionately affecting Black and Hispanic communities, ICER is basing its models essentially on data from Black and Hispanic communities that in the data set is nothing more essentially than a rounding error. Our data sets are simply not equipped to provide the kind of information we need on underserved communities in order to drive health policy. It also omits the whole idea of differential triggers. Things like pollution, food insecurity have a specific impact on the expression of disease and illness. And as we've seen very evident through the long lines for food banks in Black and Hispanic communities during COVID-19, food insecurity is not the same across all communities. Next slide, please. So this whole idea that one size fits all, for us, it's really at the core of the danger of ICER's approach and value-based purchasing. It also doesn't incorporate a societal perspective. We don't talk about the benefit to society in general of treatment. And it's not only the individual being treated, but you're alleviating the impact on healthcare workers and the danger that healthcare workers are under right now in terms of delivering services. We're not talking about the benefit to the family in general, and we're not talking about the benefit to the health system. And we're not talking, particularly in a pandemic, the kind of national societal benefit there is in terms of fear and in terms of getting back to a functioning economy. Next slide, please. The other thing we're particularly concerned about is the approach of ICER and QALYs is embedding in our healthcare system another healthcare disparity. When we use this one size fits all, when we start focusing on averages, we don't take into account the disproportionate impact on Black and Hispanic communities. And you can see from the latest data of coronavirus cases per 10,000 people the impact is not the same for all. Next slide, please. And I'll end there. And so our approach really, and our real concerns are about the one-size-fits-all approach and the lack of data that reflects the disparities that do exist in the country today.
Wonderful. Thank you so much, Adolph. We really appreciate your insight into this topic. And I'm now going to turn it over to Richard Z with the Innovation and Value Initiative to really unpack the model from an academic perspective for us. Thank you, Richard.
Sure. Thank you, Thayer, for the introduction, and also thank you, Colin and Adolph, for the very lively discussion on the public policy implications of these evaluations. My name is Richard. I am the research manager from the Innovation and Value Initiative. My background is pretty much in health economics. I was trained as a health economist. So today is a great pleasure for me to be here to discuss, some of the limitations with the existing approaches to value assessment done by ICER. And the purpose of my talk today is to start a dialogue about, some of the limitations, and then to get all of us to think about what are some of the areas that the future research should be aware of. So next slide, please. Yep. So I think, before diving into limitations, first, maybe we can quickly have a recap of the approaches used by ICER in terms of conducting value assessment for the COVID-19 treatments. In this case, specifically, it was remdesivir. So ICER mainly used two different approaches in conducting value assessment. One is the traditional cost effectiveness analysis, which was described actually by the previous speakers already. And in this approach, what ICER did is to compare the new treatment with the existing standard of care, which is hospitalization, and to try to quantify what is the additional benefit measured by QALY, and then also what is the additional cost. So based on the additional benefit and cost, there is a ratio called the ICER, which is the incremental cost benefit ratio. So that was used as a key benchmark to determine the value of a new treatment. And in this case, so the key benefits from remdesivir is really reflected in two channels. The first is the mortality benefit brought about by remdesivir. And the second part is mainly through the shortening of the length of stay during hospitalization for those treated by remdesivir. Right, so that is the first approach. And the second approach they use is something called the cost recovery approach. In this approach, what ICER did is it argues for that the price or the value of remdesivir should be based on two things. One is the cost production for an additional unit of remdesivir, and the second component is the R&D cost to develop remdesivir for this new indication of COVID-19. So those two are the main approaches used by ICER in conducting the value assessment. So these two are really bold endeavors in starting a dialogue, on value assessment for treatments for COVID-19. However, it is important for us to be aware of the limitations in these approaches. And some of these have already been described by the previous speakers. And so today I'm going to try to take a deeper dive into them. Now, before talking about any of the key limitations, I think one thing we should all be aware of is, yes, we have been in this pandemic for over half a year now. However, it is important to note that our understanding of the disease and the treatment is still pretty much premature at this point. For the disease, our understanding of the epidemiology, the pathology, the public health implication is still premature. So our understanding for the novel treatments, what is the clinical pathway for all that, those understanding are also premature at this point. So those limitations at the very start already limit our ability to conduct a comprehensive or a fair assessment of the value for any treatments or vaccines. Yes, thank you. So, so the first point I wanted to make is in terms of the model inputs. So there is huge uncertainty in terms of the underlying clinical evidence regarding the prevalence of COVID-19 and also any sort of treatment effectiveness or safety of novel treatments, in this case, remdesivir. So given the limited data, we really do not have a strong indication of like when and for whom the therapies will work most effectively. We really don't know what proportions of patients will benefit because we lack comprehensive data on patient characteristics. And that data is fast evolving because we keep collecting more data. So the constant update of data and the data uncertainty will fundamentally undermine any sort of early analysis. And as I'm sure you guys probably know, ICER has already recently updated its analysis based on the peer review results from the clinical trial ACCT. And in this updated analysis, they actually found that the mortality benefits brought about by remdesivir has actually been weakened even more. So that calls into question, because one of the main key clinical benefit of remdesivir is through its reduction in terms of mortality. Next slide, please. So the next one is in terms of the flexibility in terms of model structure. So because of our lack of understanding of the disease and the clinical pathway, so how do we select the most appropriate model structure to model the effects of a treatment is actually still unknown at this point. And so there's a lot of uncertainty. And if you examine the two models in greater details, you would discover that the current approaches are limited in terms of its structural assumptions. And while ICER was trying to incorporate some exploration in terms of the structural assumptions, it's still relatively limited in terms of its exploration. So to really conduct a comprehensive assessment, we really need to evaluate a range of assumptions that will give yield to a more comprehensive and nuanced discussions on value for treatments or vaccines. Next slide, please. And the third point is, so ICER typically use a threshold to evaluate the cost effectiveness of a new treatment. And in this case, it's worth noting that ICER actually scaled down the threshold a little bit for pricing to be $50,000 per QALY for this treatment to be considered as cost effective. And ICER, in their report, did not really give a lot of justifications, for why this was lower from the commonly used $150,000 per QALY to this new level. So, well, in our belief, in IVI's past work, we typically believe that this type of change should be based on a comprehensive stakeholder dialogue, especially during the public health crisis, which really affected every walk of life in our society. Next slide, please. The next point I wanted to make is actually has already been mentioned by the previous speakers, is the societal impact. Because it's such a pandemic that really affects every walk of our life, the societal gain from any sort of treatment or vaccines is likely to be huge. So in their report, ICER has actually acknowledged that the omitted impact of the new treatment on healthcare system capacity and healthcare personnel. However, you can think of it as an lower bound for estimate. However, the gain or the savings there could be huge. Another thing I want to point you to is the International Society for Pharmacoeconomics and Outcomes Research actually convened a special task force in 2018 to really expand, on other concepts of values beyond the net cost and net QALYs to really consider in value assessment. And now more than ever, I feel like this is something that's so relevant here. So let me give you, it's a few examples of some of these elements. These included fear of contagion, severity of the illness, insurance value, value of hope. So all these elements are especially relevant at a time like a pandemic, which really help us understand, what is the potential value of any potential treatments or vaccines, and also to add to the list, productivity. And that is something in any value assessment that we should be aware of and try to incorporate. Next slide, please. And the last point I wanted to point out here is, really the long-term impact of how we establish a value assessment framework. for the first treatment or potential treatment for COVID-19 here. So how value is determined will affect the pricing of it. And the pricing of the first treatment really has huge implications on the future incentives to innovate. So this really should be done carefully and more comprehensively, and we should really try to strike a balance between access to these new treatments and also the incentives to innovate down the road, both again for treatments and vaccines. Next slide, please. So to just summarize a little bit here, so I pointed out 5 key limitations that we identify for the value assessment framework done by ICER. At IVI, what we have done in the past is we developed this open source value assessment platform, and we had 2 disease-specific models, one focused on rheumatoid arthritis, and the other one focused on non-small cell lung cancer. Throughout these efforts, so we really have identified 4 key principles that we truly believe in and advocate for in value assessment. One is consensus. Really, especially in the pandemic, we need consensus from every stakeholder in the society to agree on the value framework method of assessment. Flexibility, because of the uncertainty in terms of data structure, we should allow for greater exploration of the flexibility in terms of inputs, structural assumptions to really get us a more unbiased estimate for the value of any treatments. Transparency, this should be done in a very transparent manner. People can easily access and understand and comment. In open source, we believe that value assessment like this should be made open source. So different stakeholders can participate and provide their feedback and comment. Last slide, please. Yes, so at the end, I think, one of the thought that I wanted to actually share with everyone is it's also important to keep in mind that value assessment is really just the first step. And there are, as the previous speakers have pointed out, there are huge public policy and health implications here as well. One is the distribution of treatments. We're likely to have a limited capacity for production at the very beginning. Who should get it first? How do we ensure access for vulnerable communities? The second part is really the investment on long-term public health. I think COVID-19 has really exposed a lot of the weaknesses in our society, and particularly in terms of, infrastructure, so a hospital capacity, and also exposed our weakness in terms of the R&D investment for infectious diseases. So these are really all the areas that we ought to think about as we continue this dialogue on value assessment. Yeah, that's all I wanted to share with you today on from a scientific and value assessment perspective.
Great, thank you, Richard, and thank you to all of our panelists. We really appreciate it. We are going to open for questions right now. I'm going to stop sharing my screen for a moment so that I can look into the Q&A button effectively, and panelists have the opportunity to answer questions directly. And then if we need to come back to the slides, we certainly can. Right, thank you. So we have one question about whether we'll be sending the deck. We are sending the deck around and are recording this webinar, so everyone will have access to it after the fact if you would like. Do we have other questions? That is the only thing I'm seeing so far. So if folks have questions for any of our panelists, now would be the time to type into the question and answer queue or into the chat box. And we have this great panel of experts here to answer them for you. All right, well, seeing none, I guess I'll turn it open to our panelists. Is there any, now that you've all heard each other speak a little bit, are there any other comments that you would like to make or pieces that you would like to highlight for our participants here today?
It looks like we do have a question coming up from a few places.
Yeah, I see that. I think while we're giving people time to type in though, if anyone has comments they'd like to make, we can share among panelists. So Colin, did anything strike you from Richard or Adolph's presentations?
I think Adolph's comment about racial disparities in who is being infected was really telling and really important to not lose sight of. You know, people are talking about this pandemic as, oh, it's affecting all of us. And it is affecting all of us, but it's not affecting all of us equally, right? Here in Massachusetts, we've seen the cities overwhelmingly that have the highest infection rates are the ones that are majority people of color. I think it's critical that, like, if the data we have is not representative of the communities that are getting sick, it's going to lead to bad conclusions. So thank you for bringing up that point out.
Thanks, Colin. So we have a couple questions, Colin. I think both of these would be best directed to you to start, and then I'd love others to weigh in. The first question we have from Siri Vaith with CFRI is, which states still have discriminatory crisis standards of care in place?
So that's a good question. I haven't, I don't know as well as some people. Center for Public Representation are the ones who've been spearheading this nationwide. I know that quite a few states, including ours, including here in Massachusetts, still are using the sort of long-term survival as a criteria. I believe Pennsylvania standard also still includes that. Several others as well, where they're saying, you know, we will allocate resource treatment preferentially to people who are predicted to live longer for reasons unrelated to COVID-19, right? So it's, you know, if person A is predicted, you know, has diabetes, and person B doesn't have any pre-existing conditions, person B would be at priority for getting, say, a ventilator. Even if that diabetes has nothing to do with the likelihood of surviving COVID, it's that the person with diabetes would be predicted to have less long to live. Fewer life years would be saved by saving their life, so they would be the lower priority. We think certainly that's discriminatory.
Right. Thank you, Colin. I have another question that I'd like you all to answer, but I'm going to start with Richard, since this probes into some health economic questions. One attendee has asked if any of the panel members have opinions as to an alternative to QALYs. Colin, I think you will have some good thoughts on this as well, and you too probably, Adolph, so maybe we can do a round robin starting with, actually, Colin, you're unmuted. Colin, why don't you start us and then we'll go from there.
Yeah, in short, clinical metrics. There are countries that don't use QALYs, most notably Germany, because the German government didn't, for some reason, want to use a metric that valued some people's lives less than other people's lives. So I don't think you need to value life at all to evaluate treatments. What you do is, for each diagnostic category, physicians, experts, and patients work together to determine what the relevant clinical metrics are, and then you evaluate drugs or treatments for that condition based on how much bang for the buck you get in those metrics. So for cystic fibrosis, it might be lung function, for example. It's, okay, this drug costs this much. The existing drugs for this cost, you know, this much per treatment, and they deliver this much improvement in lung function. How much improvement in lung function per dollar do the existing treatments provide compared to the new treatments, right? This is known as the efficiency frontier approach. That is objective. It's based on a real number. It shows you how valuable treatments are. It sorts out effective treatments from treatments that are just, you know, Me Too treatments or out to make a buck. It lets you bring down prices, but it doesn't at any point involve saying that the life of someone with cystic fibrosis is worth less than the life of someone who doesn't have cystic fibrosis. So that's my overall suggestion. There are more sophisticated analyses out there. Jaime Caro has done some great work on this, but at its core, I would say, if in doubt, use real clinical data to make these decisions.
Thanks, Colin. Adolph, you're nodding your head. Do you want to chime in on that?
Yeah, absolutely, clinical data. I think what people have to understand is that QALYs are offensive to our values as a nation. It was offensive to the Germans. It should be offensive to us. And we're advocating for eliminating QALYs in any use. We should be focusing on clinical metrics. And there are two other comments I'll make. One is the whole idea of scarce resources. Sometimes we buy into that too easily. And it looks like we're about to have an election in part about what investments we want to make in healthcare as a nation. And that's less a statement of economics and more a statement of national values. And the third point is QALYs are inherently discriminatory. There's no way to get around it. Focusing on clinical metrics allows you to take into account a much broader range of information. It lets you identify persons with certain who may be more at risk. It lets you take into account differences in environmental impacts that may make a difference in clinical outcomes. It lets you account for race, ethnicity, gender that may have a differential in clinical outcome. And in the case of COVID, we know that if infected, there are certain populations that will have a much worse outcome. So if at the initial stage of any new therapeutic or vaccine, there are limited numbers, we know to get that to the folks that are going to suffer the worst outcomes first, so that we bring down those numbers of bad outcomes. But again, I would say that, you know, it's a false narrative, this idea about limited resources. It's really a statement about our national values in terms of what we invest in.
Thank you, Adolf. And Richard, I want to allow you to speak a little bit too. Maybe you can tell us a bit about IVI's multi-criteria decision analysis work and how you've been able to create some more sensitive models using that methodology.
Right. Oh, Thayer, thank you so much for that. Because actually that's what I was about to say. So yes, like I think, you know, as we have all learned in the session, like QALY itself has its limitations, is by no means a perfect metric to make decisions. And so at IVI, in order to expand upon QALY, so we really have done two things. So one is really try to account for the novel value elements, such as value of hope. So we try to find ways to quantify those so they can actually be, you know, evaluated and brought into the value conversation. So secondly is, you know, Thayer, you mentioned about multi-criteria decision analyses. So there are actually a lot of alternative approaches in decision science and so on, and actually has been used in other countries as well, that we can use to make decisions in healthcare system. And so multi-criteria decision analysis, MCDA, so what it does is it actually brings the stakeholders and brings them engaged in the process from the very beginning. So we let them elicit, you know, their priorities for decision making from the very beginning. And they will speak about their priorities in terms of, you know, clinical outcomes, their life outcomes, and, you know, different aspects they care about. And then with those analyses, with those inputs, then we can actually map that into like a composite score based on the ranking of the relative importance. And then that way it will allow them, you know, each stakeholder to make decisions on, you know, treatment choices, treatment pathway that is the most personalized and most effective, you know, given their decision needs. And then on another layer, so all the different stakeholders can come together and also look at different decision criteria and talk and also discuss what is the best for society as a whole. So yes, another approach is bring people from the very beginning, try to use the best data we can available, have them ranked the importance, and then, you know, we can evaluate different alternatives. Yes.
Great, thank you, Richard. That's really helpful. And I know you guys are doing some really good work in that space. So thank you for that. I see one more question in the Q&A that I'm going to field to our panelists. As a reminder, type into the question and answer box if you have questions. We'll sort through them. Colin, I think you probably have this off the top of your head, so I'll direct this to you first. Do you know how any of the following would score? And if not, perhaps we can do a connection afterwards where you can share this information. The questions on MS, mental illness, HIV, or liver transplant, and what those utility scores are.
Yeah, so this is a case where I could actually use one of the slides that I had prepared, if we can go to those. But yeah, in short,
Yes, I can get those.
for each, there are a utility weight will be calculated for each sort of major diagnosis. So those would all have a QALY weight, a standard QALY weight, sometimes one in each country. So yeah, so exactly. So this is what's done. So to try and figure out what that number is, what that share is for a condition in more detail, it's a two-step process. The first is this survey called the EQ5D. And it's a 5-question survey given to people with the condition. It's the same survey essentially for every condition. Usually there are some alternatives that are used sporadically, but this is the main one. It's 5 questions, one about mobility, one about self-care, one about how well you can perform your usual activities, one about pain, one about depression. The primary one that's used are 3 options each. There's a new one that sometimes goes up to 5 options each. You have to answer every question. The problem is the way this survey is constructed really doesn't understand the way disability actually works. So looking at that options there for mobility, right? The only options you have to describe your level of mobility are, I have no problems in walking about, I have some problems in walking about, I am confined to bed, right? I suspect there are people on this who would not be able to answer in any of those categories. So people with the condition will be given this survey. They'll come up with, on average, people with this condition report these levels across the 5 questions. And then next slide. They'll then do the telephone surveys I mentioned before, where they'll call people up on the phone and they'll say, again, using spinal cord injury as our thing here, but this could just as easily be something like serious mental illness or HIV or MS. Those all have QALY weights. Those were calculated by calling people and saying, okay, you could choose between a number of years of life in perfect health or a larger number of years with MS, let's say, and people with MS report on average, some difficulty walking, being unable to wash or bathe themselves without assistance, severe pain, moderate depression, some difficulty performing their usual activities. And those randomly called, like those opinion polls will determine, the response people to those opinion polls will determine a number for how valuable the life of someone with, say, MS or HIV or a mental health diagnosis is. Often there won't just be one number, but there'll rarely be more than, say, 3 or 4. There might be, I know for MS, there's like I think a severe MS, a moderate MS, a mild MS, and a sort of MS in remission weight, I think, are the options. But still these very broad categories, each of them with a percentage of the life of a non-disabled person, the life of a person with that level of MS is worth. I hope that clears things up a bit. I think we can stop slide sharing.
That's helpful. Thank you, Colin.
I would just bring up one point that we haven't brought up is, I do think we need to remind ourselves how the whole effort around value basing is running counter to today's advancements in science. We are moving to a system of precision medicine. And one of the things we are concerned about is the whole effort to come to a single national number and enshrining that in our healthcare system is going to become a barrier to the advancement of precision medicine, which in our mind is finally going to get us to a healthcare system that best serves the needs of all persons.
Thank you very much, Adolf. As we are coming up on time and promised a hard stop, I'll ask participants if they have one more, piece of wisdom you want to share, and then I'm happy to field questions to individual participants if people have things that occur to them after the webinar.
Great. I'll use my time. I want to answer what Danny put in the chat. I will just say briefly, personally, and I think most of the advocates I've worked with in terms of COVID, I do think that saving the most lives is a legitimate method. I don't think it's discriminatory to allocate treatment if there, say, aren't enough ventilators to go around based on someone's likelihood of surviving COVID itself, right? Save the most lives with the resources you have. But I don't think it's fair, I don't think it's not discriminatory to say these 2 people have the same likelihood of surviving COVID, but we think one of them has less long to live for other reasons, so we're going to put them at lower priority for care. And Danny, I'd be happy to talk more one-on-one if you wanted to follow up afterward and put you in contact with other folks as well.
Thanks, Colin. And Danny, I'm happy you have my contact information, so I'm happy to connect you directly to Colin if you want to continue that conversation. Richard, Adolph, any final notes of wisdom for our attendees?
I also want to, respond to what Danny said here. Yes, I think at IVI, we're really trying to find ways to bring different stakeholders together. The more we can talk, the more we can understand each other's pain points and priorities, the more we can come together to make decisions. And I know those must be really tough decisions. And I can't think of a model necessarily to, to make that decision easy for anything. But I think we just need to keep communicating, keep learning about each other's needs. And that's how we can get through this together.
Great. Thanks, Richard. Adolph, parting words?
Wear a mask, make a donation to a frontline health organization.
Perfect. That is the ideal way to end. Well, thank all three of you for your time. We really appreciate it. Thanks to all of you who tuned in. And again, if you have additional questions, please reach out to me and I will either answer them or connect them to the appropriate person to answer them. Thank you so much.
Great.
Thank you.